This is Jerry Hesch of the Hesch Institute in Aurora, Colorado. And my client injured his right foot and knee in July, so 7 months ago. And he was playing basketball for an hour and a half, and then after playing, then he noted soreness and ache and tightness in his right ankle. And so I'll show you his pain drawing here. So you can see he marks on both sides of the knee, okay, and then he marks both sides on the posterior view. And then on the foot, he marks the anterior portion of the foot and the toes. So I'll let you describe what you feel in the foot.
Achiness, compression in the ankle area, and then on the pad of my foot, right below my ring toe, it almost feels like there's a clicking on the pad that kind of shoots up into my ring toe, and it's really kind of limits me on how I can move and get around.
And you saw a podiatrist and got an x-ray and an injection and insoles, correct?
Correct.
Okay. Alrighty. You certainly present with different behaviors in your feet. Okay. So I'm lifting the foot straight up. That's ankle dorsiflexion, and there is a distinct reduction of dorsiflexion in the right ankle. And I'm palpating the front of the talus, the ankle bone, and this is distinctly forward. Okay. I also find your lateral malleolus, which is part of the fibula bone, to be more forward than the other one. And if I test posterior movement, I'm springing that lower joint on the left side. Do you feel that little tiny spring? Mm-hmm. Little tiny bit of give. And then if I go superiorly, there's a little bit of movement, just a very small amount of movement in that joint. And then I come behind the knee, just below the knee, to the back of the fibular head. And I don't think the camera view can capture this, but it's you have that little bit of movement. I'll go ahead and change that angle. And my camera person is not here today. All right. So the fibula is the outside bone of the lower leg, and it makes the fibular head right here, just below the patella. Okay. And I'm coming behind it, and I'm stabilizing the tibia, and I'm trying to pull it up and out. There's no give there at all. That joint is stuck. Okay. Whereas on the other side, we have good motion there. All right. So now we'll come back and look at the feet again. I'm now looking at midfoot pronation. So I'm capturing the navicula and the cuneiforms, and there's that little bit of play. Do you feel that? Mm-hmm. And I can also traction them towards my nose. On your right foot, there's no give there. Do you feel that?
Yeah.
Okay. And then when we come down to the cuboid, you find it by walking down the outside of the metatarsal, and then you add one finger and one more, and right there's the cuboid. And I'm trying to move it up and down. There's no movement there. When I come to the other one, there's distinct up and down motion. Okay? The calcaneus, it does rotate outward. The back of it goes outward, so then the foot goes inward. Okay? Now I'm going to do outward motion of the calcaneus, so the foot would go outward. I'm pulling the back of the heel to the left, twisting it. There's just very little movement, then it runs out of motion. And then I can't get any more motion. Okay? You seem to have, your foot is positioned in inversion. Okay? And if I try and push it outward into eversion, I can push it out to a stop point, and there's a little bit of play there. I'm surprised at that little bit of play. I thought it would be absent. On this one, I can push it out, and then I can spring it, and there's that little bit of play. And when I twist the back of the heel to the right, then the front of the foot goes outward. So this motion is much freer. Okay? Okay. So we have reduced motion in the ankle joint. We have an absence of discernible mobility throughout the fibula. We have blocked up and down mobility of the cuboid, and the ankle doesn't dorsiflex as much. It doesn't come. The foot doesn't come up as much, and midfoot doesn't pronate, dropping that arch. So there is much to work with. Separately, I will film his knee presentation. That'll be a separate video. But I'm going to go to work on restoring motion throughout this foot and ankle. And you read, there's several articles in the literature dating back to 1981 on cuboid syndrome. I think Robert Parks in Albuquerque did the first published article in that. I could be wrong, but that's my belief. And they talk about doing a cuboid whip, where you come underneath the cuboid and you push up and whip it up and outward, okay? But in this presentation, his cuboid is already up and outward, okay? There's an article in Journal of Orthopedic Sports PT, and they talk about the fact that the cuboid does move up and out in rotation and down and in rotation. And I think they recognize that there's two different ways of mobilizing that. My belief is that this cuboid needs to be mobilized inferiorly and medially, but I'm not able to directly mobilize the cuboid because it's controlled by the midfoot and it's controlled by the calcaneus in the calcaneo-cuboid joint. So my freak flag that I'm flying is that when you have a painful stuck cuboid, don't mobilize the cuboid because you're in the wrong joint. It's controlled by other joints. And so what I need to do to free up cuboid mobility, so here's cuboid right here, all right, you can see how it connects to the heel, okay? So we need to restore appropriate motion of the heel, of the calcaneus. And then just above that is fibula. We need to restore motion there. Talus is right here inside that ankle below the tibia. This is tibia. This is fibula. So there's talus. Okay, we need to restore motion there and restore pronation of the midfoot. And if we do restore those movements and restore movement of the rear foot, being able to move in the transverse plane and also being able to abduct, then the cuboid should be happy without me directly mobilizing the cuboid. Okay? And so I'm going to show very quickly how I'm going to accomplish this. I'm going to get underneath the fibula and I'm going to push up with moderate force, and I'm going to oscillate that 30 times. Then I'm going to come on the front of the lateral malleolus, bottom of the fibula, and I'm going to, with the heel of my hand, capture it, and I'm going to push it downward towards the floor. I'm going to maintain that force for 2 minutes, okay? Then I'm going to have him on his stomach, and I'm going to lean on the back of the fibular head, and I'm going to glide that fibular head forward and outward slightly. Then I will distract. Oh, sorry. After that, I'm going to mobilize the talus posteriorly by scooping the calcaneus down and up, and then oscillating it posteriorly. Sometimes you see clinicians just mobilize the talus directly like this, or do it like this. But I really believe you need to scoop that heel, scoop that calcaneus down and up, and do those together. So that's the technique that I will use, okay? And then I will capture the midfoot and I'll traction it towards me, towards my nose. I'll oscillate 30 times. I'll keep that stretch, that distraction, and then I will mobilize it medially. And after all those motions are restored, I'll come back and I'll test the cuboid, and I think that the cuboid will then have normal mobility. So I will go to work now, and I'll film the response to treatment, except let's capture two more behaviors. Pull the left foot up and out, and then show me how strong you are. Don't let me drop it. Keep it up and out. Beautiful. Nice. Very strong. Good. Do the same thing here. Up and out. And don't let me pull it down. Ready? 1, 2, 3, go. You'll notice that I can break that. Okay? So there's some muscle inhibition. Let's look at your balance. Let's have you step over here. And then stand on your left leg. and then stand on your right leg. So it's subtle. What do you feel?
Definitely more unstable on my right.
Okay, very good. All right, lie on your back and we'll go to work.